Welcome everyone to Starling Training, a new approach to fluid management. Our main learning objectives for today, we're going to focus on four main topics. First is going to be sepsis, septic shock, and refractory hypotension. We're going to describe sepsis and septic shock and the pathophysiology of hemodynamic instability and how that plays into fluid responsiveness. We're also going to summarize resuscitation in the post-EGDT era, which also stands for early goal-directed therapy, and how the concept of fluid responsiveness has evolved over the last century. We're also going to summarize the impact FRESH had on sepsis resuscitation. Next, we're going to learn why we care about fluid management, what dynamic measures are, which in this talk we are going to discuss passive leg raise and a fluid bolus. And then we're also going to demonstrate how to perform those dynamic assessments at the bedside and how to add them into your workflow. I wanted to start off our sepsis talk with some statistics. First, 5.3 million deaths occur per year when it comes to sepsis. Sepsis, it is the most common cause of death in hospitals. Actually, 1 in 3 hospital deaths have a sepsis contribution. Septic shock also has the highest mortality rate, between 17 and 43%. Sepsis is also the leading cause of readmission rates for hospitals. About 1 in 5 patients will actually be readmitted within 30 days of discharge. And in other words, around 20%. That's pretty huge. And then sepsis is also the most expensive condition to treat in hospitals. So globally, we're actually spending around $62 billion a year to treat sepsis. So let's just go over some common terms and definitions. The first is going to be sepsis, which I'm using the definition from the SEP3 guidelines, is a life-threatening organ dysfunction caused by a dysregulated host response to an infection or pathogen. Now that pathogen can be bacterial, it can be viral, it can even be fungal. But I just wanted to point out that this is a dysregulated host response, which we'll get into a little bit later. The next will be septic shock, which is really a clinical construct of sepsis with persisting hypotension requiring vasopressor so we can keep that MAP above 65. And we're also having an increase in our serum lactate level despite adequate volume resuscitation. Next is blood pressure, which you guys are all very familiar with, but it's the pressure that's circulating blood against the walls of our blood vessels. So we have a systolic, which is the top number, and that's whenever our ventricles are contracting and it's at its highest point. And then we have a diastolic, which is the low number on the bottom, and that is when the heart is at rest. And then of course we have our MAP and our heart rate. So I wanted to make sure that everyone is aware that sepsis, it's on a continuum, right? We have our SIRS criteria over here on the left, and you can see that it's a clinical response that's arising from a nonspecific insult. And you have more than 2 of the following, whether you have an increased temperature or a decreased in temperature, you have an increased heart rate, increased respiratory rate, and you have a dysregulation with your white blood cell count. But as it continues, then we have a definition of sepsis, which it is a confirmed infectious process. So I'm going to kind of do an analogy with a house. Okay, so you have a house, everything looks fine from the outside, but as it progresses, we can now presume that there's something going on inside the body, even though from the outside everything looks okay. Now, whenever we start going into severe sepsis, we now have organ failure. So I kind of compare this to a house that's on fire because looking at the outside, we now see that there is a problem. We might not know what exactly that problem is, but if I'm relating this to a patient, I can see that there is organ dysfunction. So we might have a decrease in urinary output. We might have a decrease circulation with our peripherals, so our patient's mottled. So we can now see those outward signs that something is very, very wrong with inside the body. And then we have septic shock. And of course, if we do not treat that, it leads to death. So I want everyone to realize that sepsis in itself is really an issue of the microcirculation. This is where everything starts and why we can start seeing a lot of clinical manifestations when we are at the bedside and completing our assessments. So we need to start thinking, what is happening on the arterial side? What is happening on the venous side when our patients are septic? And what is happening in between? So now when we look at this picture, these circulatory paths, they also occur inside every single organ of our body, not just on the outside. So make sure you keep that in mind. So microcirculatory dysfunction leads to organ dysfunction. As I was saying on the previous screen, our veins, our venules, our capillaries, arterioles, and our arteries, they are inside of every single organ, which is why we see many organ dysfunctions associated with sepsis. Now, if you look on the screen, this is the 6 most common organs in the systems because there's a lot of variables that we are able to actually measure and trend. So if we start with our cardiovascular system, right, we typically see hypotension with sepsis. If we are not perfusing peripherally, we might see our patients having some modeling going on, maybe elongated cap refill. We might see some changes in our echo findings. We will also see that our hepatic system and our hematological systems may be affected, where we have increased liver enzymes, low platelet count. We might even see DIC. If our kidneys are not having proper oxygenation, right? We might see oliguria or low urinary output. We might see some changes in our lab values, such as increased BUN and creatinine, maybe even some biomarkers if that's something that your hospital looks into. If our brain is not being perfused, we might see our patient showing signs of altered mental status or decreased level of consciousness. And of course, with our respiratory system, our patients will be showing signs of hypoxemia and also an increase in the respiratory rate. Okay, so we're going to get a little deeper with this conversation and talk about the pathophysiology, but on a cellular level when it comes to sepsis. So how does this happen at the cellular level? So first, we have something that has caused an infection, and that infection or pathogen is recognized by the innate response. And again, this pathogen, it can be fungal, it can be bacterial, or even viral. And eventually that gets broken down into various proteins and products, commonly referred to as pathogen-associated molecular proteins, which you can see here. Those are known as PAMPs. And this activates a response called pathogen recognition receptors, which sit on cells. And in this instance, we're going to talk about a macrophage. And eventually, the macrophages act as a kamikaze pilot. And they cause damage when they're trying to get rid of the pathogen by destructing or damaging itself. But again, the point is to get rid of that pathogen in the process. And that happens through a way of producing exosomes, also known as damage-associated molecular proteins, DAMPs. And DAMPs, they're not pathogens. These are byproducts produced by our own body's destruction of those inflammatory cells. But that process activates other PRRRs, known as pathogen recognition receptors, on other cells, for example, neutrophils. And this is where we start seeing a lot of activity happen because there's toxic enzymes and proteins that are produced. And again, to help the destruction of that pathogen, but that activates other responses such as nets, which you can see over here. And nets are actually supposed to capture pathogens. And this process continues and continues, causing more pathogen recognition receptors on other cells. And this is the reason why sepsis is such a problematic issue, because this is a positive feedback loop. So it happens over and over and over again, where DAMPs activate other recognition receptors on other inflammatory cells, which create more DAMPs by destroying more inflammatory cells, which create more nets. And again, that process continues until we start seeing it on the macro level. So where this may have started in one particular organ has now spread and happening in multiple organs. So now what we're going to do is we're going to focus on how these pathogen recognition receptors, again, PRRs, are found on the endothelial cells and how that process creates the pathophysiology of what we know as extreme sepsis or septic shock. So, endothelial cells. These cells are found in the inside lining of blood vessels, lymph vessels, and the heart. So technically it's the lining of the blood vessels, but it's very, very important to remember that almost all tissues depend on a blood supply, and the blood supply depends on the endothelial cell. So this is why sepsis is so complicated, because the endothelial cells are damaged during sepsis. So the endothelial activation, there are two parts. So sepsis, again, it started with a pathogen, which our bodies initiated a chemical reaction, which in the end caused a physical reaction. So the first thing that happens is we have a decrease in vasomotor tone, all right? And if you start looking here, this NO, also known as nitric oxide, is released into the circulation, which then causes the second part of the issue and causes vasodilation of the smooth muscles in the arterioles, which you can see this is a normal artery. And now it is dilated due to this NO. So now that we have already recognized that we have a decrease in vasomotor tone, and now because of NO, we have vasodilation of our arterioles, this causes the second part of our endothelial activation process, which is an increase in our unstressed volume. So if you look at the picture to the right, if you think of the whole sum of blood supply as a cylinder, and in this case, capillaries, and you have a spout that drains the fluid or blood from that cylinder, there is going to be a certain amount of fluid that will not drain because it's below the level of that spout. Now, this fluid that stays inside the cylinder or the capillaries is known as the unstressed volume. Now, the amount of fluid that will be drained from the cylinder, this is called stressed volume. Now, this is at baseline, okay? However, when vasodilation occurs, which if you look at this picture over here, and you have a decrease in vasomotor tone. So essentially we have the same amount of blood, but it's in a different shape now. And this change now makes the unstressed volume larger, which means that we're no longer going to have more volume contributing to blood flow, which means we have less volume contributing to blood flow. So essentially what happened was the body's response decreased the amount of volume of blood that is able to contribute to blood flow and perfusion, which is the main reason why we start seeing a lot of issues with our septic patients. So what does this look like in the cardiovascular system? So looking at the venous side, which is right here, the decreased vasomotor tone issue causes a decrease in the amount of blood that's returning to the right side of the heart from the body circulation. So now let's look at the arterial side, right there. Now we have a decreased blood flow because we had an increase in our unstressed volume, also known as a decrease in our stressed volume, and because we also have a decrease in our vasomotor tone. So now we'll get a little bit more superficial with our discussion and look at sepsis physiology from an organ level. Now, has anyone heard of Ohm's law? Okay, so if you are looking up here at the top, Q, okay, this is Ohm's law, meaning flow from any sort of fluid in a closed circulation is equal to the change in pressure, which there has to be a pressure gradient, divided by R, which means resistance. So the part that we're going to be focusing on is the change in pressure, but the analogy in the cardiovascular system, we're going to talk about cardiac output as flow, which is Q. So what we're looking for here is there's a pressure in the arterioles, which is, if you're looking at this picture, on the right side, minus the pressure of the venules, which again is on the left side. So blood is flowing from arterial side to venous side. Blood is flowing from the right side in this picture to the left side. However, in order for that to occur, the arterial side needs to have more pressure or a higher pressure than the venous side. And unfortunately, when you have an increase in unstressed volume, you then have a decrease in your stressed volume. And when you have low stressed volume along with a decreased vasomotor tone, now pressure is decreased on the arterial side. So we don't have that push of blood from the arterial side to the venous side. And therefore, when you have less pressure on the arterial side, you have less blood flow in the microcirculation, which is what we discussed in the very beginning. Now, that was in the case of sepsis. However, septic shock is an extreme version of that. Now, when you lose most of that pressure differential because of a bigger increase in your unstressed volume, which causes more of a decrease in your stress volume, you have a much bigger drop in that pressure gradient. And that manifests itself in septic shock as a decrease in your blood pressure. So this is a key point. What happens at the cellular level is affecting what's happening to the body on a macro and a microcirculatory level. So how did we treat sepsis in the past? If you look at this slide before 2001, okay, and we're going to talk a little bit about antibiotics and mostly fluids, it was kind of like the Wild West. Sometimes patients would get their antibiotics right when they presented to the hospital, and some would receive them hours after admission. Some patients, when it came to IV fluids, weren't even resuscitated at all. So there wasn't really that recognition that we needed to ensure of adequate perfusion as quickly as possible to preserve organ dysfunction. That wasn't really a well-known point prior to 2001. So there was a wide variability on how these patients were resuscitated. So then 2001, Mr. Manny Rivers, he did a paper that stressed two major things. First, the importance of antibiotic treatment, which should be delivered as early as possible. And his recommendation was within the first 6 hours of diagnosis. And then we're going to go. And in this paper also stressed the importance of hemodynamic benchmarks. So CVP had the goal of making sure the body had adequate volume, whereas MAP was intended to help focus on adequate perfusion to offset the vasomotor tone problem that patients have with sepsis. And then also down here, SCVO2 was for those who had heart dysfunction during their sepsis episode, or if they were anemic, that would need resuscitation from that standpoint. And it was more so to help guide blood and inotropes as needed. Now, I want to point out that these are hemodynamic, not perfusion goals. Hemodynamic goals, they're numbers. We don't know what is right for the patient, so we have to individualize our practice. But, not to take anything away, during the time of 2001, EGDT had major advancements in decreasing mortality in sepsis, almost a reduction of 16%, showing that this paradigm of providing therapies as early as possible while sustaining organs is important. Now, because this is a talk track about fluids, we're going to talk about why we need IV fluids when we're septic. So there's a few reasons. First, the patients are typically dehydrated because they have insensible loss. So this could be from having an infection and their body is trying to fight off this infection and they start having fevers. When they have fevers, they start sweating. Also, there's an acid-base issue when it comes to sepsis. And a lot of patients start breathing faster, which is why we have a respiratory rate higher than 20 as one of our markers for the SIRS criteria. Also, when you're sick, you have poor intake. I know when I'm sick and not feeling great, the last thing I want to do is drink a lot of water. And third, there's a redistribution of fluids. We already talked about having a decrease in our stress volume, which decreases blood flow. And now we also have leaky capillaries, which we're going to get into next. But first, I just want to go over some faults and point out a few things in this EGDT study. So first of all, it was a single center study. Second, they used a lot of invasive monitoring, meaning during this study, they had to put central lines in every single patient. And third, most importantly, they had a lot of aggressive fluid resuscitation and transfusions and inotrope targets with CVP and SCVO2. So a lot of patients were receiving too much fluid because they were looking at CVP. Now, the big question is CVP the right target to look at when it comes to volume management? And I'm going to say that that answer is no. CVP, it's a very poor marker for volume status and volume responsiveness. There's a lot of studies over the past decade that says CVP is as reliant as the flip of a coin. So 50% of the time it's accurate, which means 50% of the time it's wrong. So the next big question is early goal-directed therapy generalizable today? So in 2015, the trifecta trials occurred. And this was the PROMISE trial, the ARISE trial, and the PROCESS trial. So unfortunately, the trifecta trial did not show any changes in outcomes nor mortality based on EGDT approach versus the usual care. But we have to remember that this was based off of CVP, MAP, and SCVO2. And in my opinion, the usual care has changed a lot since then. So where are we at now? Do you think that we're going to go back to the Wild West when it comes to fluid management and volume resuscitation for treating our septic shock population? In my opinion, no. There's been a lot of advancements since then, and because of the PROCESS trial, they started realizing that maybe given a little too much of the good stuff might not be the best when it comes to outcomes. For example, in the PROCESS trial, they realized that when they continued to give fluids, even though MAP was above 65, they started realizing that at 6 hours and at 72 hours, that they had an increase in fluid balance on their eyes and nose, and they also started seeing a lot more renal failure. So now we kind of have to start looking into too little, is that okay? Or too much, is that okay? So let's put this into context. Let's look at this case study. So you have an 80-year-old male with dementia presents to the ED from a nursing home with confusion. He has no records and no family present. During triage, we realized that blood pressure is 60/30, temp is high, 102.4, and respiratory rate is very high, 50 breaths per minute. Chest x-ray was complete and it shows a multifocal infiltrate, which they're thinking pneumonia. So this 80-year-old male received 2 liters of IV fluids administered and the blood pressure increased to 100/30. But within the hour, it decreased back down to 80/35. You complete another assessment, he's warm, and his mottled skin, no urinary output. So, first question, you guys. Do we administer more fluids? What do you think? And if we do administer fluids, how do we know when the patient's had enough? And I think this case study, which we see that multiple times, is starting to answer this question of why is fluid management so important? So if you're looking at this slide, let's look at the left side first. This is a fluid versus complication curve, or a Bellamy curve. But on the left side of the curve, this is where we have too little fluid on board, also known as hypovolemia. Now from a nursing standpoint, this is where our adrenaline starts pumping, because this is where our patient has a low perfusion and we start seeing low blood pressure. And when we have low blood pressure, we know we have to get it up. We have to have that MAP of 65, because if not, we're going to have tissue hypoperfusion. And when we have low perfusion, we start to see tissue hypoxia. And when our tissues and organs aren't getting the oxygen it needs to function, we start seeing organ failure. Now, this is the side of the curve that we care about. And this is the side where we start giving these patients fluid after fluid after fluid because we don't know when enough is enough. And it's really easy to accidentally tip on this side of the curve, the right side, which is too much fluid or hypervolemia. However, we don't realize the complications, they're the same on both sides. When we are giving too much fluid to a heart that can't tolerate it, what happens is it causes way too much pressure, way too much congestion, and that fluid starts backing up. And the first place it goes is your lungs, right? So we are now seeing an increase in lung water. We're also going to start seeing tissue edema because when the fluids are backing up, it actually causes organs to swell. So for example, your kidneys, they sit inside of a sac. Now, when we start having tissue edema, do you think that tissue can continue to swell in something that it's being covered by? So we actually cut off blood flow, known as acute tubular necrosis. So, too little fluids, our kidneys fail. Too much fluid, our kidneys fail, right? We start seeing pulmonary edema. We can start seeing compartment syndrome, renal failure. We need to start understanding that the fluids that we give causes the same complications as if we didn't give them at all. So research is showing that it's very, very important to stay in this optimal volume range, especially when it comes to our patient outcomes and mortality rates. Now, the two major areas that we normally talk about are your septic shock patients and your surgical patients. However, for this talk, I'm only going to talk about our sepsis patients. So after talking about that Bellamy curve and having too much fluid, right, being on the right side of that Bellamy curve, there's a lot of issues with edema, fluid going backwards, but there's also a complication of these leaky vessels. So we know that there's consequences of giving too much of a good thing. So the endothelium, it's the core cell here that contributes to a lot of the things that we're talking about and a lot of things that we're trying to correct with fluid resuscitation. So I just want to make sure you guys are aware that on this side, this is the blood side. And on this side of the endothelial is the organ side. So part of the vascular wall, also known as the glycocalyx, which in this context is going to be this blue area. Okay, there's an outer and inner layer. But this glycocalyx, it's the permeability layer of your blood vessels. It's kind of this slimy sugar coat, and it's a layer of protection for the endothelium. And it also has some impact on preserving these tight junctions. So here's one example of a tight junction, and here's another example of a tight junction, to ensure that the body's blood and fluid, it's staying in the intravascular space, so inside the vessel. And what happens with sepsis is you have an erosion of that glycocalyx, which allows for that inflammatory activation process to trigger, which is what we talked about earlier. And what also happens is it allows that erosion in these tight junctions as well, which causes extravasation. Now, this is a problem in general for patients who have sepsis. However, giving patients to fluids can exacerbate this process and worsen their condition, causing the organ edema and the tissue edema that leads to organ failure. So when we start having organ failure, it increases risk for mortality. Now, this was a study that was done in 2017 by Paul Merrick, and he wanted to see the correlation between IV fluids given and mortality in our septic shock population. Now, this was done from the 2013 Premier database. Almost 24,000 patients were included in this study. And what it showed is that on day one, for every single liter additional over 5 liters, independently increased mortality by 2.3%. Now, that is huge. So we talked about having a mortality rate between 17 and 43% earlier. The average is 33% mortality. When you get diagnosed with sepsis, you have a 33.3% mortality rate. Now, how easy do you think it is to get to 5 liters in a 24-hour period when you're treating sepsis? In my opinion, it's very, very easy. Because CMS guidelines, we're giving 2 to 3 liters within the matter of the first couple of hours of admission. Then say our patient's hypotensive and we're giving fluid boluses, or maybe we're starting maintenance fluids, and then we're giving 2 to 3 antibiotics that sit in 500 ml bags, and we're giving them every 4 to 6 hours. So that 33% mortality could be as high as 50% mortality just by adding on IV fluids, which I want to stress, IV fluids is very, very important with the treatment of sepsis. And not only did we see an increased mortality in sepsis, we also showed that for every additional 1 liter of fluid given, increased hospital costs by $999. So keep that in mind. And the reason why IV fluids play such a huge role with mortality and sepsis is because only 50% of hemodynamically unstable patients respond to IV fluids. Only 50%. However, a question I'm going to leave you with is, what percentage of patients that have low blood pressure do we give IV fluids to? So how do we prevent over-resuscitating or under-resuscitating our patients? Well, a lot has happened over the last 10 years, and the answer is we assess for volume responsiveness. That is, are fluids going to increase my cardiac output? And that is the answer. So let's just pretend we're back in A&P 1 and 2, okay? The Frank-Starling law. So the first place I want you to look is the x-axis. This is our preload. In preload, it's the amount of blood that's returning back to the heart, allowing the right side of that heart to expand and fill. Now, once those elastic fibers expand, it gets that snapback contraction to eject that blood forward throughout the circulatory system. Now, in this picture, we're talking more about the left side preload, pushing that blood, which is carrying all that oxygen and nutrients, from the right side to the left side and back into circulation. Now, the y-axis over here, this is stroke volume. And this is the amount of blood that's being ejected back into the systemic circulation. So, fluid responsive, okay? Now, when I say fluid responsive, that means our stroke volume increases by 10% or more. This is the fluid responsive side of the curve. This is where we want our patients to be. Now, when you provide some sort of preload that's returning to the heart, you will see an associated increase in the amount of blood that's being pushed back into the systemic circulation. That is the goal. Now, what we don't want to see are patients on the right side of the curve, where they're considered non-responders, meaning their stroke volume does not increase by 10% or more. That means if you gave them a fluid bolus or you increase their preload on the left side of the heart, that there is a very, very minimal increase in the amount of blood that's being pumped back into forward circulation. Well, how do we find out if someone's fluid responsive or not? And the way is a passive leg raise, which is an excellent diagnostic test. Now, I'm a very visual person, so if you look at this graph here, this is our baseline position for a passive leg raise, meaning the head of the bed is up at 45 degrees, the legs are flat. You want to make sure that SCDs are turned off. Remember, this is the only time in your nursing career you want blood to pull in the calves. So SCDs are off and pillows are out from under the legs. Now, all of these little black lines, this is stroke volume. And remember, stroke volume is the amount of blood that is ejected out of the heart with every single heartbeat. This is my blood flow. Now, what we did is we laid this patient flat and we put legs in the air at a 45-degree angle. And now we can see that this patient's stroke volume is increasing. So if you wanted a visual, if someone was volume responsive, this would be it. Now, what we did is we laid this patient back up. All that blood that was in their chest cavity is now going back to their calves, and we decide to give them a 500 cc bolus. And while infusing that 500 cc bolus, we see that the stroke volume has increased. So again, this patient in this scenario is fluid responsive. Now there are 3 major reasons why we suggest completing a passive leg raise. First, it's faster for nurses at the bedside. Second, it is the best diagnostic test on the market. A passive leg raise to determine volume responsiveness is more accurate, more precise, more reproducible than a troponin we draw every day to detect a MI or a Bunning creatinine to detect renal failure. On an ROC curve, it's 0.95, meaning it is 95% accurate. Again, better than any other test on the market. The third reason is because it is the safest test for a patient. The reason why it is safe is because it is reversible. So when you guys have patients that have renal failure or congestive heart failure, and we're really nervous to give IV fluids, this is a perfect patient population to try a passive leg raise on. Because if you look in this picture, a passive leg raise, it is a predictor if volume will work. So say you have a patient who has congestive heart failure and you lay them down and you put their legs in the air and their heart cannot tolerate that fluid and we see a decrease in their stroke volume, again, which is the total opposite effect we want to see. That's okay. We're going to abort the mission. We're going to sit that patient up. All of that blood is going to leave the chest cavity, go back to the calves, but we now have our answer that we cannot give that patient fluids right now. So we just prevented someone from being fluid overloaded. So again, a passive leg raise is reversible. So where are we at now with passive leg raise and dynamic measures? Again, 2001, we were all about Wild West, cowboys, go get 'em, do whatever you want at the bedside. And then Manny Rivers changed some things around, talking about early goal-directed therapy when it came to hemodynamics and antibiotic. Well now, 2004, the Surviving Sepsis campaign, we were still a little outdated. The Surviving Sepsis campaign said that they wanted to use crude metrics such as blood pressure and urinary output to identify patients that were adequately perfused. However, with that, we saw tons and tons of fluids being administered to these patients. And then, going a couple of years later, Surviving Sepsis campaign of 2012, there started to be a change in the language where they started discussing the use of hemodynamic improvement based off dynamic measures, such as pulse pressure variation, stroke volume variation, or static variables such as arterial pressure and heart rate. And once they started incorporating these dynamic changes, we started to see perhaps that less fluid was being administered to these patients. Again, not less than what they need, but enough to sustain perfusion. And then 2016, most recent version of Surviving Sepsis, they actually recommend dynamic over static variables to predict fluid responsiveness, to help guide fluid resuscitation. Again, dynamic measures and dynamic assessments such as passive leg raise over static variables such as CVP, blood pressure, and urinary output. So you guys, we're getting there. And the study that changed it all, fresh. Fluid response evaluation in sepsis, hypotension, and shock. So this study came out in 2020, unfortunately right in the middle of COVID, but there was 2 questions that this study was asking. 1, can stroke volume guided dynamic assessments guide the amount of IV fluids in patients with sepsis, associated hypotension, and septic shock? And the second, Can the difference in fluid administration lead to improved outcomes? Now, the fresh trial methods, this looked at septic shock patients. They also were looking at a passive leg raise to guide decisions on pressors versus fluids for clinical hypoperfusion. So this was a randomized trial, unblinded. There was a 2-to-1 ratio, so double the amount of patients that were on the stroke volume guided resuscitation group versus the usual care group. This occurred in 13 different sites between the US and the UK. The recruitment site was in the ED, and of course we wanted those patients to then follow to the ICU. And they used the surge criteria with a suspected infection. There was a small N number of 124 patients, again 83 in the treatment arm, also known as the stroke volume guided arm, versus the 41 patients in the usual care group. However, what's fantastic about this small N is there was a lot of statistical significance and clinical significance, which we'll get into next. There was some exclusion criteria. So if the patient could not complete a passive leg raise, they were excluded out of this study. Also, if the patients received more than 3 liters in the ED, they were excluded. And there was also some other reasons that they were excluded, such as if they were going to the OR and they could not follow the algorithm, or say they had other causes of hypotension and it was not due to sepsis. Now, this is the resuscitation protocol that was utilized in the FRESH study. This is open to the public. However, you can see at the very top, the clinical decision is made to treat the patient with either fluids and or vasoactive medications due to either 1, MAP was low, or systolic blood pressure was low. There's either low urinary output, or there was any other clinical indication to administer fluids or pressors. So it really allows the physician to decide what to do next with a little guidance. So the FRESH primary endpoint was to show the fluid balance, which did favor the treatment group. There was 1.37 liters less on I's and O's after 72 hours. As far as the secondary endpoints, FRESH was looking at renal replacement therapy, which again favored the treatment group. The treatment group had 5.1% needing RRT compared to the control group, which needed 17.5%. Mechanical ventilation. Now this was the initiation of mechanical ventilation. However, it was almost a 50% reduction, 17.7% versus 34.1%. They also looked at ICU length of stay. Now, although this was not statistically significant, it was clinically significant, favoring the treatment group by less than 3 days in the ICU. And another endpoint was looking at the patients being discharged home. So 20% more patients in the treatment group actually were able to be discharged home alive compared to the control group. Now, looking back at our retrospective study that was done in 2017 at KU, there's a lot of similarities when it came to our outcomes. Again, you can tell we had less fluid balance when we looked at a stroke volume guided approach. We also had 3 less days in the ICU. We had less vasopressor usage. Mechanical ventilation was cut in half. And again, acute dialysis was cut by 2/3. So the way that we administer IV fluids really makes a difference when it comes to our patient outcomes, as well as the economic value. So it is clear that FRESH made a huge impact in the sepsis world, showing that today using dynamic measures such as the passive leg raise and guiding our fluids to stroke volume really makes an impact in our outcomes as well as our mortality rate. So although passive leg raise should be the default dynamic measure to use when assessing volume responsiveness, not all patients can tolerate a passive leg raise. So some common contraindications could be acute respiratory failure. If you are on ICP precautions, say you have a trauma and have hip dislocations, or say your patients don't have legs, so bilateral amputees. Now, if you cannot do a passive leg raise, you can of course do a bolus challenge. Now, a passive leg raise, you're taking a bolus from their legs. Again, Your calves hold about 250 to 300 cc's of blood, and we essentially are translocating that blood from the calves to the chest cavity. Now, we can also give a bolus through a bag. However, a bolus test is mimicking what a passive leg raise does, so that fluid needs to get in just as fast. So you will have to utilize a pressure bag, for example, to get those fluids in fast enough. Now, I will say there are some limitations and more user error when it comes to a bolus challenge. For example, if your patient only has a 22 gauge IV, I'm not sure if fluids will get in fast enough with a 22 gauge IV. Or say your patient has an IV in the AC and that patient is constantly moving their arm. So those kind of interventions and situations can cause your bolus challenge to not be as accurate. So always keep that in mind. And if you don't want to do a bolus challenge, you can also trend. So when you are in an ICU, an ED, or a PACU, OR, a PCU, if you are using titratable drugs, you should always be utilizing hemodynamic monitoring. That way you can individualize your care and help titrate your medications to make sure that what medications you're using, whether it's IV fluids versus pressors or inotropes, it's working for your patient and it's benefiting them. So what do you do with your results? So what we're looking for and what we are hoping for is to see a patient's stroke volume index increase by 10% or more. That means the patient is volume responsive, meaning additional fluids will likely improve perfusion. Now, this data definitely needs to be used alongside with the patient assessment. Now, just because someone is volume responsive, if you will look down here at the bottom, does not mean you have to give IV fluids. This monitor is not prescriptive, okay? Now, same thing goes the other way around for if you are not volume responsive. So if the stroke volume does not increase by 10% or more, that means additional fluid will unlikely improve perfusion. Now, the whole purpose of giving IV fluids is to increase blood flow and increase perfusion. Therefore, if we're not increasing perfusion, there's no purpose in giving those fluids. I want to make sure that you are aware that this monitor, it is not a wet or dry monitor. This is talking about cardiac perfusion, cardiac function, and can the patient's heart push that fluid forward in the correct direction to supply the organs with nutrients and oxygen. So you can have someone who is intravascularly dry who may need fluids but not be fluid responsive, meaning their heart can't tolerate those fluids. So at that point, when you have someone who is not volume responsive, you want to look at cardiac index and TPR to see if vasopressors or inotropes will be effective with your patient. Maybe you can actually change the way that heart is functioning so the patient can tolerate IV fluids. Now, I think this is a great slide to show the comparison between blood pressure, pressure-based measurement, and cardiac output as your flow-based measurement. So in order to perfuse your organs, you need perfusion and flow as well as a pressure. So how do they work together and how do they work against each other? So this was a study that was done in 1944 using 7 male subjects. And what they did is they put catheters in their veins and they bled themselves out until they fainted. And they were being monitored while doing so. Now, if you look at the screen, this area right here is venous section where they start to bleed out. The 2 main areas I want you to look at is blood pressure. So this is my pressure-based measurement, and my cardiac output, which is my flow-based measurement. Now, cardiac output equals stroke volume times heart rate. So this again is my flow-based measurement. We need both. So if you look up here at blood pressure, they start bleeding out, my blood pressure goes down, and then it goes up. Why? It's because of compensatory mechanisms. My heart rate, for example, will go up because my body starts noticing that I'm not perfusing the most important organ of my body, which is my brain. So my heart rate increases to compensate for the lack of flow. Another thing that happens is TPR. You might know it as SVR, but stands for total peripheral resistance. This is also known as your afterload for hemodynamics. So this is a normal vessel, this is a constricted vessel, and this is a dilated vessel. So essentially what happens is our body shunts blood away from our fingers, our toes, our bowels, our kidneys, because again, it wants to perfuse our brain. So our vessels start constricting to get our pressure to go up. However, they're compensatory mechanisms. So once those fail, the blood pressure just tanks right before they faint. Now, if you look at cardiac output, immediately when they start to bleed out, cardiac output and flow just start to decrease and decrease and decrease because there's nothing that compensates for flow. So first, the whole purpose of this is to show you the difference between blood pressure and flow. It's also wanting to show you that by the time you see your patient who has low blood pressure and a systolic in the 60s, their body has already been in a compensatory state for a period of time. Their body has already had low perfusion. Their body has already had cell death by the time you see it at the bedside. So blood pressure is a very late sign. And third, because there's no compensatory mechanisms for cardiac output and flow, we can use these devices such as cardiac output and stroke volume to see what's around the corner, and instead of being reactive, let's be proactive. So how do we manage perfusion? Make sure you understand the equation for cardiac output. Cardiac output is heart rate times stroke volume, and stroke volume is made up of these three parameters: preload, afterload, and contractility. So when you are at the bedside and you see your patient has a perfusion issue, the first assessment you can complete is a passive leg raise or a fluid bolus to determine preload status. If a patient is volume responsive, you can give IV fluids in hopes that it'll increase your cardiac output, your perfusion, or your blood flow. Say your patient is not volume responsive. You can look at your total peripheral resistance on the Starling monitor. Say your TPR is low, meaning you have low resistance. You can use vasopressors for those dilated vessels. Say your TPR is high and you have high resistance. That means that your vessels are clamped down and maybe we need to give some vasodilators. Or if your cardiac output is low and your preload is normal and your afterload is normal, let's see if we can help with some inotropes. So you can figure out what your patient needs to perfuse all at the bedside utilizing the Starling monitor. So putting it all together, your cardiac output is made up of heart rate and stroke volume, and your stroke volume is made up of three things: preload, afterload, and contractility. And make sure that when you're looking at your numbers, to understand that all of these variables are dependent on one another. The amount of preload can negatively impact your contractility, and the amount of afterload can impact your contractility. So you have to ensure that all variables are within their normal limits. So just to look at the big picture when it comes to hemodynamics and sepsis, because I know we went on a macro, micro, organ level, cellular level. Now we're just going to look superficial and see, hey, there's an infection. Whether it's in the blood, it's in my lungs, or my kidneys, I have some sort of inflammatory state, which releases these vasoactive materials and toxins into my blood. And those blood vessels then dilate. So then fluid leaves the blood vessels, my blood pressure drops, and then my heart tries to compensate by increasing the heart rate. And as fluids continue to leak out and blood pressure continues to drop, cardiac output is not enough for the body's metabolic demand, and it just keeps going into this positive loop. So what we're starting to notice is back in the old days, protocolized ways of doing things versus individualized way of doing things to treat patients. They would always go head to head. But what we're starting to notice, especially with FRESH, is having a standardized approach in place so you can individualize therapies is the best way to take care of our patients. Now, bringing the Starling monitor into this, I wanted to just show you some visual cues to help you remember. Stroke volume index. V is for volume. Always look in this top left box. It's blue. I remember blue is like water. This is your flow. So when you're doing a passive leg raise, you're looking at this number and our hopes are to see it go up, which means we're increasing our blood flow. TPR. TP is for pressure, R is for resistance. P is also for purple. So your third box to the right, this is your TPR. In order to get this number, you either have to hit on that TPR box and hit enter map, enter the patient's map that's showing on your bedside monitor, and it will give you your value. And down here, it'll tell you when you're inside or outside that normal range. And if you are outside that normal range, it'll give you a little yield sign to remind you, hey, look, this is not normal. But again, TPR is referring to your afterload. And last but not least, contractility. I couldn't think of anything that started with a C, so I just put a lemon on here to show for when I am contracting and squeezing a lemon. It's yellow, and this is what you're going to be looking at. Cardiac index. Now, as you can tell from the screen, cardiac index or cardiac output equals heart rate times stroke volume. So our monitor gives you stroke volume. From there, everything else is calculations. I quickly wanted to make you aware for the Step 1 guidelines for your 3 or your 6-hour bundle. A fluid challenge or a passive leg raise is a part of that 6-hour bundle. So by utilizing the monitor, completing a passive leg raise, it can help your Step 1 scores, which are publicly available. And we also have studies showing that utilizing the Starling technology as a tool can help improve your Step 1 compliance. So we do have studies to prove that data. So to wrap it up, the Starling easily integrates into your workflow. You first have to identify, do I have a blood pressure or a perfusion problem? If you do, your next question is always, do I need fluids? Well, how do we determine if we need fluids or not? Well, we do this by completing a passive leg raise or a fluid bolus challenge. If my patient is fluid responsive, then yes, I can go ahead and give fluids. However, if they are not fluid responsive, now let's look, do I need pressors? Let's look at my afterload and my TPR. Or if not, let's look at inotropes for my contractility. As far as sensor placement, there are 4 sensors total. You need 2 sensors above the heart and 2 sensors below the heart. However, when you are using the upper sensors, you want to look at these tabs, which you can see here. It will highlight which quadrant you need to put these tabs in. So when I'm putting the upper sensors on, I always suggest hugging the trap or hugging the clavicles, but do not go below the clavicle. This monitor is looking at aortic outflow, and your aorta sits up pretty high. So when you put a sensor below the clavicle, you miss some of that outward flow. As far as the lower sensors, symmetry does not matter. So you can put the left quadrant down here and the right quadrant down here. However, if they're an obese patient or they are abdominal breathers, say they have a colostomy bag, you can put them on the sides of the body or you can put them on the flank and on the back. So again, symmetry does not matter. These sensors are good for 48 hours. So once you put them on, you leave them on and utilize the passive leg raise or those dynamic assessments multiple times during that 48 hours to reassess your patient. You also want to make sure that these little white tabs are always facing towards the toes or tush. So tabs to toes, tabs to tush. These sensors can go in CT, they can go in X-ray, but they cannot go in MRI. Also, this monitor is not defib proof. So if you have an emergent situation where you have to shock your patient, just make sure that the monitor is looked at to make sure there's no electrical interference before you use it on another patient. There are some tips right here for sensor adherence. You can clip or shave the hair if necessary. You can also wipe the skin with smoothing paper that is also located inside the sensor package. Do not place the sensor on a lot of hair or a hairy patch. The skin should be clean and dry. And if you want to make sure there's extra stability, you can put a transparent dressing over your sensor in case that patient is diaphoretic. Also, look down here for recalibrating. Per our FDA approval, you should recalibrate every 24 hours. However, at the bedside, I would suggest to recalibrate once a shift. You also need to recalibrate if any or all sensors are moved or replaced because it's based off where that sensor is located. Now this slide helps you decide when you're completing a passive leg raise versus a bolus test how to complete those dynamic assessments. Now remember, whether you're doing a passive leg raise or a bolus, you need to do a 3-minute baseline. However, with a passive leg raise, that baseline is in this position. With a bolus, a baseline position does not matter. You just want to make sure that whatever position the patient is in during the baseline, they continue to stay in that same position during the challenge. Now, this will also tell you, so you don't have to remember, if you're giving a fluid bolus, you want a 250 bolus in less than 5 minutes or a 500 cc bolus in less than 10 minutes. Now there has been an upgrade on the software for completing a dynamic assessment such as the passive leg raise. So after you get your 3-minute baseline, in the past you had to do a 3-minute challenge with legs in the air. However, if your delta change is more than 10% within the first 45 seconds, you can actually end the test early. So you will keep legs in the air until the patient's stroke volume index increases by 10% or until that 3 minutes is up, whichever one comes first. The reason you can end a test early if they are volume responsive is because the percentage change is not equivalent to the amount of mils to give. So for example, if I have a patient that is 10% responsive, that does not mean that patient can only tolerate 250 cc's versus someone that may have a stroke volume index change of 88%. That number does not mean they can tolerate more fluid than the person who had a 10% increase. So if a patient is volume responsive, they're volume responsive. And literature actually shows that when you're giving a fluid bolus, you should only be giving 500 cc's at a time because again, you don't know where your patient sits on this Starling curve. Now note the delta change in the stroke volume percentage highlighted on the screen down here. This will be very, very helpful for you guys when you are trying to chart your results. You will have your baseline numbers, your challenge numbers, and then you will also have your delta changes in your stroke volume index, cardiac output, and heart rate. Now, if you're having issues with the monitor, troubleshooting, here are some helpful tips. So always check your sensors. Are they placed correctly? Are they more than 48 hours old? Remember, you also have to be 2.5 inches away from a pacemaker. So if you have a pacemaker in the left upper quadrant, make sure that you are putting the sensors on the back of the body so it's away from the pacemaker. Now, our monitor does not affect the pacemaker. However, the electrical interference from the pacemaker affects our machine. Now, if you don't have any issues with those, all you have to do is recalibrate your monitor. Also, make sure you check the wires to make sure your red sensor is connected to your red cable and your black sensor is connected to the black cable. Also, make sure your patient's height, weight, and age are correct in the monitor. And lastly, in the top right of your monitor, you will have an info button for troubleshooting. However, my name, my number, my cell, my work cell, and my email is located on the monitor. If you have any questions, please call. I'm more than happy to help. I know this monitor like the back of my hand and can answer any questions you may have. Thank you guys.